Alrighty, ladies and gentlemen, let's talk therapies, shall we? Um, we've got a variety of different therapies based in the different um, perspectives that give rise to different kinds of treatment, right? And so we're going to go through these one by one. And now, for most of the psychological treatments, we've covered at least some of this in different chapters, so I'll probably buzz through these pretty quickly, but I want to make sure that we've got them all in one place. So let's talk about our psychological therapies first. These are going to be focused on the causes of psychological disorders being in the mind, right? And so it's a question of trying to treat how people are thinking about things, how they're responding to others, and how they view themselves in order to try to um, eliminate troublesome behavior and help a person feel better about themselves. Now, the first one to talk about is psychoanalysis, which is the type of therapy that Sigmund Freud came up with. He was really one of the first psychologists, and in fact, he was operating before we even really recognized psychology as a field into and unto itself. He was one of the first sort of famous psychologists as he went along. Um, he was really one of the first to come up with a unified theory for treatment and to come up with his own style of treatment that differed in any meaningful way from medical treatments. So he is the one who engineered and pioneered talk therapy, as I believe I've mentioned before. That idea of sitting down on the couch and talking to a therapist who is taking notes and sort of guiding you through your thoughts and your feelings in a systematic way. This is something that Freud came up with, and even though a lot of his ideas turned out to be not reproducible or not well supported by empirical research, just for that alone, we owe a debt of gratitude to Freud for popularizing this idea that you can talk about things and come to resolutions and improve your life by doing so. Um, his name for this kind of therapy was called psychoanalysis, where the therapist's job is to try to reach beyond the person's conscious mind into their unconscious and interpret what comes out of the unconscious. So there are different ways that he felt that unconscious material can bubble to the surface. That can either be through the analysis of dreams. He felt like in fact, he called our dreams the royal road to the unconscious mind. So he felt like you could, as a trained psychoanalyst, interpret what a person was dreaming about and identify what the unconscious mind is concerned with or hung up on. There are other ways that the unconscious mind can come to the fore. He advocated for free association exercises where you were supposed to, as the patient, clear your mind and respond without thinking to things as the therapist then gave you prompts. So the therapist says red, and you say whatever comes to mind. Or the therapist says mother, and you say whatever comes to mind. And you're not thinking about it too deeply, you're just sort of spouting off whatever comes out, and that sort of quieting of the conscious mind is supposed to allow the unconscious mind to come forth and reveal what its concerns are. One of the other ways that he felt like this could come out is in what he called parapraxis, which we commonly call Freudian slips, where you intend to say one thing and you end up saying something else. And he felt like that had meaning. That was the unconscious mind taking advantage of distraction and slipping in some true thing that you're not aware of. The therapist then identifies what the unconscious concerns are, helps bring them to the person's conscious mind so that they can work through them. Oh, you're really concerned about the fact that you had a poor relationship with your mom when you were very little, and let's talk about that, right? Let's work through that. Let's try to resolve some of those concerns, right? So once the unconscious is made conscious, then the person can be aware of their own anxieties and can try to reduce them with the help of the therapist. Freud thought this was likely to take years over the course of sort of weekly meetings. These days, psychoanalysts try to get to the point a little bit quicker. As we talked about last time, you've got the whole managed healthcare situation where insurance companies don't want to pay for you to go to therapy for years and years on end. And so rather than focusing on what your relationship with your mother was or what your relationship with your father was when you were very little, modern psychoanalysts will probably try to focus in on more current concerns and try to resolve those rather than going back to the beginning, because it just takes a whole lot longer. All right, humanistic therapies are based in the idea that humans are inherently good, and if you treat them as good, they will behave goodly. That's not the right way to say that, but it is the right idea. That we misbehave as humans because we get treated poorly by our parents and our authority figures when we behave in ways that they don't want us to. And if we could just get to a point where we believe that we are worthy of respect, love, and attention, regardless of how we behave, then these folks felt like you would likely stop acting out in negative ways because you wouldn't feel the need to. You're not trying to live up to any external standards, and as a result, you can be your best self. Now, that's a lot of these ideas came from Carl Rogers, who, once again, I talked about when we were talking in another chapter about him. He really thought the idea was to give unconditional positive regard as a therapist, right? If you can teach people and make them feel like they are worthy of your attention and respect, then they will act as if they are worthy of your attention and respect. And that then eliminates a lot of the problem behaviors that people have. The other aspects of therapy, according to Carl Rogers, was showing empathy for people and being genuine in your responses to them. Now, being any one of these three is not necessarily terribly difficult in any given moment. Being all three of them at once can be very difficult as a therapist, right? To be empathetic with the individual as they're talking about the bad things that they've done, while not losing your genuineness, where they may be talking about something that you find personally abhorrent, and also still treating them as if they are worthy of your respect. This can be very difficult to do. However, these therapies do tend to, at least under certain circumstances, perform as well as more modern therapies. And so I think there's really something to this one. Behavioral therapies are based in the concepts of behaviorism, shockingly, and we've talked about these before. These are based on the principles of classical and operant conditioning. So, systematic desensitization is the idea that you take whatever the feared object is. This is a therapy primarily for specific phobias. And you gradually introduce the feared object while teaching the person to relax, and they will then undo the pairing, the classical conditioning pairing of that object and a fear response. Works pretty well, actually, in fairly short periods of time. Flooding is a similar idea, although seems a little more cruel, if you ask me. With flooding, you actually expose the person to the maximum strength exposure to the feared object, right? So if somebody's scared of snakes, you dump them in a pit of snakes. The idea there being that the problem is the person's irrational fear, this classically conditioned fear of that object, and they fear they're going to die, that the exposure to that object or that situation will kill them. Well, you get dumped into a pit of snakes, and so long as it's under controlled conditions, you're not going to die. You know, I dump you into a pit of garter snakes. That's going to be frightening. It's going to freak you out. Heck, I don't even have a phobia of snakes, and that'd freak me out. But the body can only freak out for so long, right? That fight or flight response that we have is necessarily of short duration because it expends all of our energy. So you are going to calm down inevitably as you are sitting there in that pit of snakes. And eventually you will realize, I'm not getting bitten, I'm not getting poisoned, this may not be my favorite thing in the world, but it isn't going to kill me. And therefore that will undo that classical conditioning. Now, once again, I think this is a far less pleasant way to go about it than systematic desensitization, but there is some research support that suggests that flooding does work. Aversion therapy is using the principles of classical conditioning to create new conditioning, right? If there is some behavior that you don't like, you try to pair it with an unpleasant stimulus in the hopes that that will then reduce the occurrence of that behavior. This is sometimes used, not much anymore, but has sometimes been used for people trying to stop drinking, right? The therapist will allow them to drink during their session, but will put a nausea-inducing drug in the alcohol, and that then, over enough pairings, creates the expectation of nausea when exposed to alcohol. That's unpleasant. The person doesn't want to drink anymore. Now, the problem with this is that you can't actually, as a therapist, follow a person around and poison all of their drinks because you'll get arrested. And it's just not feasible, right? You have a life to live yourself. And so the person can then, after that session, go to their favorite bar, and they're not going to get nauseated from that drink. And so what they end up nauseated by is your presence, because you're the only reliable pairing with that unpleasant feeling. There are other ways to go about this. I know for myself, there was a time period in which I found myself swearing a little bit more than I found acceptable. I was a young man, maybe 20 or so, and so I put a rubber band on my wrist, and every time I caught myself saying a bad word, I would just snap my own wrist. Now that sort of crosses over between classical conditioning and into operant conditioning, where you're talking about rewards versus punishments. But you could think of that as classical conditioning, and the pairing of the unpleasant snap of the rubber band against your wrist, pairing that with the use of particular words. You're probably going to use those words less often. And then token economies, we've talked about before as well, where if you've got control of the situation, of a person's environment, then you can have anything be a reward, right? In inpatient scenarios where people are being treated for eating disorders, for instance, they will frequently use phone calls as a token economy. It is something that can be controlled and therefore doled out only for the behavior that is desired. So if the person who is there because they're struggling with anorexia or with bulimia, for instance, if they eat their 3 square meals in a day, they get a 10-minute phone call home, right? Obviously, they have to confiscate their cell phones when they go into the inpatient scenario, or else this doesn't work, right? You don't have control over the resource. But a phone call, you don't normally think of a resource or as a reward even, but if you control the entire environment, then you can set up all sorts of things to be rewards that wouldn't normally be so. In prisons, frequently guards and wardens will use cigarettes as rewards because they're hard to get, right? You can't run to the store and get a pack of cigarettes, and so they will hold that out as a reward for the desired kind of behavior from the inmates that they're looking for. It then turns into an entire black market within the prison where cigarettes get exchanged like cash, right, for goods and services. Anyway, that is another way in which the principles of behaviorism get applied, not only in real-world scenarios, but also in therapeutic ways. Okay, moving on to cognitive psychology. This is the idea that, yeah, actually, it's not just behavior. We do care what's going on in the mind. So let's think about that. Let's focus on that. The basic idea for all cognitive therapies is that a person holds an irrational belief that leads to disordered behavior. So if you can restructure that person's thinking, the troublesome behavior is likely to go away. Um, you've got a variety of different researchers and therapists here. One of the early ones was a guy named Albert Ellis. He came up with what he called rational emotive behavioral therapy. He's an interesting one because while we tend to think of therapists as being, kind, caring, sensitive folks who, are listening to you talk and care about your feelings, Ellis was having none of it. Right? He thought that it was the job of the therapist to confront and challenge the client on their irrational beliefs. And so he was okay with being a little combative with his clients. And so if somebody was thinking an irrational way, he would say, "Hey, this thing that you're thinking right now, that's wrong. Let's talk about how that's wrong. Now stop it. Knock it off." Right? You know better. So whether or not that's effective, I mean, cognitive therapies are effective. Let's talk about just sort of like a basic idea of what cognitive restructuring might look like before we go any further. This is, let's say that you've got someone who is a student who is really struggling in their classes and about to drop out of school. Um, they are likely, especially if you're dealing with someone who is on the level of disorder where it's diagnosable, likely to be experiencing depression and anxiety as a result of their trouble in school. Well, there's going to be a lot of irrational thinking that goes on as a part of that depression and anxiety. And so that's what the cognitive therapist would focus on. Okay, so what's going to happen if you fail this class? Well, I'm probably going to have to drop out of school. Mom and dad will be so upset with me. It'll ruin our relationship. I will feel so bad about myself, and I'm just never going to recover from that. Okay, let's look at all of those assumptions and talk about them one by one. If you fail this one class, will you have to drop out of school? Let's calculate what your GPA is going to be if you get an F in this class. Oh, that takes you from a 3.1 down to a 2.75. Is that so bad that they're going to kick you out of school? No. So, are you going to get kicked out of school if you fail this class? What really will happen if you fail this class? How are your parents likely to respond? Well, they're just going to be so upset. Yeah, probably. They want you to do well. Are they going to stop loving you? Are they going to kick you out of the house? Are they going to stop helping you? That seems less likely, right? Let's talk about what would really happen if you called mom and dad and told them you failed a class. And so you try to replace the irrational beliefs with more rational ones so that then the person can respond in more rational ways. If you're not seeing the situation clearly and you have false expectations for what is likely to occur, it's going to lead you to engage in behaviors that are based on those assumptions that are likely to then lead to those assumptions. And so if you can replace those irrational beliefs with more rational ones, the person is likely to behave in a more rational way and is likely to cause fewer problems for themselves. The ideas of this cognitive restructuring have then been married between the idea of cognitive psychology and the ideas of behaviorism to create what we call cognitive behavioral therapy, which is really one of the gold standards for therapy today. Because it approaches this idea of cognitive restructuring while at the same time using some of the principles of operant conditioning to change people's behavioral patterns while at the same time trying to change their thinking patterns, right? So you can think of it as a feedback loop, right? How you think about things informs how you behave. How you behave informs how you think about things. How you think about things informs how you behave. right? And so it goes back and forth, almost like a spiral. Now, if your thinking is irrational and your behavior is irrational, then you get a downward spiral, back and forth of irrational behavior, irrational thinking leading to irrational behavior, leading to irrational thinking, leading to irrational behavior. However, cognitive behavioral therapy says you can attack this from both sides. So it's the therapist's job to not only provide the client with some cognitive restructuring, but also with behavioral scripts where let's target this troublesome behavior and give you some alternatives. Next time you find yourself wanting to scream at your mother because of whatever it is that your issue is in that moment, I would like you to try one of these other behaviors instead. I'm going to give you some scripts. Mom, when you say that, I feel. Or you could, if you're too upset, you can walk away from the conversation. So providing some alternative behaviors instead of the usual behavior that someone will enact and that will lead to this sort of same outcomes that they're used to getting if they're fighting with mom, let's say. That's just a random example. So not only can you help the person change how they are thinking about their interactions with mom, and that will hopefully lead to some different behaviors, you can also then help them find some different behaviors and give them, you even engage in some role play there in the therapy so that the person has some practice doing something a little bit different rather than responding as they always do. So if you behave differently, that's likely to lead you to think differently. And so you're attacking it from both sides. You have twice the likelihood of success. And this is a type of therapy that tends to work quite well in a broad variety of scenarios. And in fact, you've got all sorts of different named therapies that are just cognitive behavioral therapy as applied to depression, or as applied to anxiety, or as applied to borderline personality disorder, or any of our others, right? And so you get these different therapies, these different named therapies that are all at their base cognitive behavioral therapy. Okay? All right, so that's our psychological therapies. There are others, of course, but those are our primary ones based in the perspectives that we've talked about this semester. Let's talk about biological therapies. Now, when you think of biological therapies, what we're talking about is coming at it from the biological perspective. Something is wrong with the body and with the brain. Let's try and figure out what's going on that's wrong with the body and the brain, and that is likely to resolve whatever the disordered behavior or thinking is, right? Now, one of our primary types of biological therapies is medication, one of the most popular ones, but there are some other ones that we're going to talk about as well. So, let's talk about our different kinds of medications, and this is going to be a 5-minute history lesson on psychoactive medication. Our first psychoactive medications were barbiturates, developed in 1903, if I remember correctly. These were intended as anti-anxiety drugs, and were, in their day, up through about the 40s and 50s, very commonly prescribed for a wide variety of feel-bads, right? Whether it was anxiety or depression, these were medications that were given to help people feel better. They were powerful drugs. Unfortunately, they were quite habit-forming and really easy to overdose on, and so they became quite popularly used in suicides. Right around the 1940s or so, we developed an alternative kind of anti-anxiety drug that we called benzodiazepines that are still widely used today. Valium is a benzodiazepine. Xanax is another one. Those had fewer side effects, were a little safer to use, harder to OD on, and so replaced barbiturates. And barbiturates actually are off the market entirely at this point because they were just too dangerous, too easy to overdose on. Because anxiety disorders and depressive disorders are frequently comorbid, meaning the same person will end up with both of those disorders, you do sometimes get these anti-anxiety drugs still are prescribed for depressive symptoms as well. However, for our depressive disorders, we do have a different class of drugs, antidepressants, you've heard of, um, that are focused specifically on the neurotransmitters that are related to mood. One of the most common ones is the class of drugs known as SSRIs, selective serotonin reuptake inhibitors. Essentially, what that does, and we talked about this when we were talking about neurotransmitter functioning, um, when we talked about the brain in like chapter 2 or 3. What SSRIs do is the serotonin that moves from one neuron to the next, that gets released into the synapse, um, generally gets vacuumed back up by the um, axon terminal so that it can be reused, right? That's the process of reuptake. What SSRIs do is slow that process down so that the serotonin is hanging out in the synapse for longer. It can bind and then rebind to receptor sites so that with less serotonin, you end up getting more action out of that same serotonin. And this is one of the problems that folks with mood disorders tend to have, is low levels of serotonin in the brain. And so that increase in action from those serotonin molecules allows the person to have a more stable mood, because those junctions, those synapses where serotonin is being released, are synapses related to, a lot of them at least, mood regulation. Okay. There are other kinds of antidepressants. There's SNRIs, which target not only serotonin but also norepinephrine, which is another one related to mood regulation. You've got tricyclics, which target those same two neurotransmitters but in a different way. And then you've got MAOIs, which target serotonin, norepinephrine, and dopamine as well. There are certain individuals who are simply not responsive to certain antidepressants. And there are sometimes even the case where you've got somebody who is responding well to a particular antidepressant, and then for whatever reason it just stops working on that person, and so then they have to change medications. And so somebody who's struggling with a mood disorder will frequently need to go back to their psychiatrist or their doctor a variety of times because their antidepressants aren't working. And it's just a question of zeroing in on the one that works for that person. Okay, that's it for antidepressants. Mood stabilizers. This is a particular class of drugs that is intended to treat bipolar disorder. And there's really only one drug here, lithium salts. That's been reworked into a variety of different drug names that are, proprietary and whatever, but at their base, they're all lithium salt. This is an interesting drug because it only works on people with bipolar disorder, meaning if you don't have bipolar and you take lithium salt, it's not going to do anything to your behavior. But for someone who has bipolar, it will help smooth out their highs and lows, because remember, with bipolar disorder, you have manic episodes and depressive episodes, and the lithium salts help the person maintain a more stable mood across a long period of time. Now, it's hard to get folks with bipolar to take their meds because, as I mentioned when we talked about bipolar in the last chapter, they like their manic episodes. They feel good when they have those. An additional difficulty is that lithium, being a metal, builds up in the body, and so it can be easy to overdose and get symptoms of toxicity, lithium toxicity, which is nausea and vomiting and seizures. So folks who are on lithium salts have to have their blood levels of lithium monitored on a regular basis to make sure that they're not developing toxic levels in their system, right? Okay, last category here is antipsychotics. These are drugs intended to treat schizophrenia. Schizophrenia we had no idea to treat until about 1950 or so. So folks with schizophrenia just ended up in mental hospitals for the rest of their life, for the most part, because they couldn't manage themselves. Now, interestingly, a French surgeon in the 50s, was experimenting with a class of drugs. The primary drug is Thorazine. Um, he originally intended it as a drug to help with recovery from surgery. He thought it would help folks recover more easily from surgery. But what he noticed was that his surgery patients who happened to be schizophrenics benefited greatly in terms of their stability after they took Thorazine. And so he then, wrote up those findings, and those got disseminated to other researchers and doctors, and Thorazine became the go-to drug to help people with schizophrenia because Thorazine seemed to eliminate or greatly reduce the occurrence of hallucinations and reduce the strength of people's deluded thinking, delusions. Um, and as a result, they were able to manage their lives in a way that they previously weren't able to. If you think that you're being pursued by the FBI and you're actually hearing voices telling you to run, it's going to be really hard to get through your day. If those suddenly go away and suddenly you're like, oh, why was I thinking the FBI is after me? That doesn't make any sense. Well, then you can go back to work and you can manage your relationships and things get a little simpler, right? And so a lot of people who were previously in mental health care hospitals were released because they could then manage their life again. This actually had the knock-on effect that was unexpected of the closure of a bunch of mental health care hospitals across the country. And actually, as these folks then didn't have these places to go back to and didn't necessarily always stay on their medication, it led to an increase in homelessness, which we're still trying to deal with in our society now. But that's a whole different story. No, those are typical antipsychotics. Are your Thorazine and other drugs derived from it. Was another style of drug that was developed a little bit later in the 70s, I want to say. Clozapil is one of them. Chlorazil. I'm sorry, Chlorazil. These are atypical antipsychotics. They work in a different way. It turns out that nearly a quarter of folks with schizophrenia don't respond at all to Thorazine, right? So it just didn't help them in the slightest. These folks then tended to respond better to Chlorazil and other similar atypical antipsychotics. The atypical ones tend to do better at reducing the negative symptoms of schizophrenia and don't have as severe side effects as Thorazine does. Thorazine can lead to severe tremors and some other pretty negative side effects. So roughly half of folks diagnosed with schizophrenia today receive atypical antipsychotic medications. Okay, so that's our major classes of drugs. Once again, there are plenty of others that we haven't covered, but this covers our major types of medications for our psychological disorders. Now, pills aren't the only way to do it. There are other ways to affect the body and manage symptoms of psychological disorders. Now, one of these early on was used for schizophrenia and was entirely ineffective. Electroconvulsive therapy was originally intended to shock individuals. Let me just describe it first, right? So these days, in modern electroconvulsive therapy, what is done is the person is given a sedative and a muscle relaxant so that their muscles don't seize up. And then electrical current is applied to the head, passes through the brain, and it would induce seizures if the person didn't have the muscle relaxant in their system. Now, this was used minus the muscle relaxant for folks in the 30s, 40s, and 50s when they had schizophrenia. It was entirely ineffective. They were just throwing things at the wall to see what stuck, and that one didn't stick. It didn't help at all. But what they did notice is that there's schizophrenic patients that also had mood disorders, like depression, felt a whole lot better about themselves after these ECT sessions. And so ECT continues to be used today as an alternative treatment for severe depressive disorders. Now, it is sort of the therapy of last resort for depressive disorders because it does have some negative side effects, including memory loss. Right, roughly a quarter of patients treated with ECT experience autobiographical memory loss. Now, not complete loss like I don't know who I am anymore, but rather things like I don't remember your birthday anymore, or what's the dog's name, or things like that. Now, so it's got to be pretty severe depression in order to deal with those side effects, and it needs to be a depression that is not responding to other therapies, right? So you're going to your talk therapist and you're taking your medication and still the depression's not getting better. Well, electroconvulsive therapy may be the way to go then. Psychosurgery is also an option for particular disorders. That's when we cut open your head and cut out little bits of your brain. Now, in past decades, past generations, there were very crude versions of this. And in fact, psychosurgery is one of the earliest known therapies that we have record of, because we have found prehistoric skulls 10,000 years old that have the top of the skull drilled out. So the damage to the bone shows that the person actually survived it, right? I won't go into the details there, but yeah, these were people who had the top of their skulls sawn off, and they survived it, and apparently continued to live for decades beyond that. It is thought that this therapy, which is called trepanation, the cutting off of the top of the skull, was used to let demons out of the person. That's our best guess, right? We don't know. We don't have records of it. And you would think, well, why on earth would they do that? Well, people have done pretty much everything under the sun, but why would they do that and keep doing that? Because there's actually quite a few of these skulls out there that have been trepanated. Trepend? I don't know. At any rate, why would they do this? Why would they keep doing this? Well, because in some cases it worked. Right? If you've got somebody who is acting erratically, raving, possessed by a demon or a spirit, under certain circumstances, that could be caused by inflammation to the brain, of the brain. Now, if you cut off a piece of the skull, that would allow the brain, in its inflamed state, to expand beyond the limits of the skull. If that, whatever is causing that inflammation, whether it is a bacterial infection or a virus or whatever, if that then resolves itself, the brain is going to deswell, the person will heal back over, they'll have a soft spot on top of their head, but they'll be fine, right? So in certain circumstances, they drilled out the top of people's skulls, and then they got better, right? And then they healed, and they continued on. So that was, a very crude kind of psychosurgery that was done tens of thousands of years ago. Now these days, well, moving a little bit further forward in time, you go to the early parts of the 1900s, and there was a practice called lobotomy, where surgeons would go in and remove parts of the frontal lobe of the brain. This left people non-functioning, essentially vegetables, where they had to be cared for the rest of their lives, either in some sort of mental health care hospital or by their families. And in some cases, they were done for the most ridiculous of reasons, like, dissatisfied housewife goes to the doctor and says, I can't take it anymore. They go, well, we'll give it a lobotomy. And then, well, mom's not upset anymore, but she's also not mom anymore. So once up to like 30,000 lobotomies were performed over the course of like 1910 to 1950. Once it came to the public consciousness that this was going on, people got outraged and it stopped happening. These days, we do still do psychosurgery under limited circumstances, but we're much more targeted. So if you've got a part of the brain that is overactive, say it's causing seizures, so the person has epilepsy, or they have obsessive compulsive disorder and it's not responding to other therapies, we can go in and target the specific parts of the brain that we know to be overactive and just create a tiny lesion, a little cut in the flesh of the brain, or a tiny bit of cauterization where you burn those particular neurons so that they don't heal, they don't come back, and then that overactivation goes away, right? And so we don't do this often, and only in severe cases, but yeah, very targeted neurosurgery where you're going in and creating small lesions, that does still occur under certain circumstances today. Sometimes you've got underactivation of the brain, and so we need to stimulate the brain. We can do this, it turns out, with magnets. Transcranial magnetic stimulation is the name of this therapy. And what it will do is it seems to act as a sort of reset button for different parts of the brain. It is effective in certain cases for schizophrenia. Folks treated in the temporal lobe, which is the auditory centers of the brain, where they get a 10 or a 30-minute treatment where magnets are applied outside the head, and it changes the blood flow and the electrical activity in that part of the brain during that stimulation. Folks with schizophrenia report a reduction in their auditory hallucinations of up to like 18 weeks after a single session of transcranial magnetic stimulation. So that can be very good for that. Actually is very bad for obsessive compulsive disorder. It actually appears to make it worse, so you don't want to use TMS for OCD. And then last on this list is bioneurofeedback. There are certain systems in our body that we don't have conscious control over. However, when given feedback about what's going on, we can manipulate those systems in our body. And we may not even necessarily know exactly how we're doing it. But for instance, if you are given a running, readout of what your blood pressure is, and you can actually lower your blood pressure by trying to do so, whether that's through deep breathing or meditation or other mental exercises. You can actually affect some of these things. We took that principle and then applied it to brain function, right? And so there are games that have been developed even. So you can see this young man is actually playing a game with his brain. And they've even tried to commercialize this over the last few years, where there are brain interfaces, things you put on your head that allow you to control particular games. They're not very popular yet because we're not very good at it yet. But this young man, for instance, suffers from ADHD, and what he is doing is changing the function of the part of his brain that is being monitored by these electrodes. When he does so successfully, then the character on the screen moves forward, and he moves forward in the game until he wins, right? Now, how exactly do you get the person to change their brain function? Well, I don't know. It's I'd have to be a little bit more well-versed in this. But to the best of my knowledge, it's learning to think about particular things or think in particular ways that changes the electrical activity in particular parts of the brain. If that's what they're targeting, then they could pick that up with those electrodes, and then if that's hooked up to the computer, then that can do whatever the coding wants it to. Move the character forward on the screen, swing the sword, whatever the case may be. And these sessions then can train kids to increase the activity in certain parts of the brain and decrease it in others. and help them manage their symptoms of ADHD pretty successfully. And this is one that is really exciting because it's widely applicable. I actually have a nephew who is planning to go to grad school in this field, working with neurofeedback to help folks manage their epilepsy. So, as you can see, it's not just medication we're talking about with biological therapies. There's lots of other options as well. And that's it for therapy. That's it for treatment. We've reached the end of these slides, so I'm going to sign off for now, and we will come back to you later. Have a great weekend, everybody.